Hello and welcome to the Atrómitos podcast. I am the host and producer, Liz Church. I am pleased to welcome back to the Atrómitos Way, Miss Jai Smith. She is an advocate for health equity and reducing barriers to care for gender-expansive communities. Hi, Miss Jai.
Hi, thank you for having me back.
Of course, absolutely. So to kind of set the stage of exactly what we're talking about for folks listening, maybe you've seen articles, social media posts, or overheard conversations from friends, neighbors, and colleagues about the far-reaching and dangerous playbook of Project 2025, aimed at seizing control of the United States government and dismantling the country into an authoritative state. And I wrote about the quotes written in this disastrous book in my worried, tired, frustrated piece for this year, 2024, and maybe you've heard the audio version a few weeks ago. And while this plan specifically targets explicitly marginalized communities, it's an insidious attack on bodily autonomy, threatening the freedom and rights of all Americans. And we're not going to give a play-by-play of what this stupid thing says, as there are many other experts, and we have articles, podcast episodes of other people who've done a deep dive, and I will absolutely load those into the episode show notes. But instead, Miss Jai and I are going to talk about how this will broadly impact care and what we can do to fight back and protect our freedoms. So let's just jump into it. I wrote my piece, what it was, and the worried, tired, frustrated, was the attack on reproductive health, how it extends beyond cisgender women, impacting all individuals who seek reproductive care. And I gave a little bit of snippet of how this will affect LGBTQ plus communities. And for where we're going to go back and forth on this is that we've seen the attacks of abortion widely in the past 2 years since the overturn of Roe versus Wade by folks who were wholeheartedly against it. Of course, if you don't want to have it, that's perfectly fine. That is your choice. That is the reason for it being a choice. Abortion is mentioned in 60 pages of this 922-page document. And they really don't like cisgender women making choices on their own healthcare. But at the same time, they really don't like the LGBTQ community to exist, to have a choice of who they want to be and how they want to live. So I wanted to give you the stage, Miss Jai, to go ahead and give us a little bit of a breakdown of how this will affect the LGBTQ plus community.
Yeah, thank you for having me, and thank you for highlighting that this is really a much larger conversation about bodily autonomy and about our ability to be self-deterministic in the ways that we lead our lives and engage in relationships, in family building, in family planning, etc., and in our wellness and our well-being. So for folks who aren't familiar with me, I am not a paralegal. I don't have a legislative background. I don't have a background in political science or political policy. My background is in public health, and my background is in healthcare, and specifically public health and healthcare for LGBTQ communities, trans and non-binary communities is where I spend a lot of my time and my focus and my energy. And so some places that I want to start around this, because the document is extensive. It covers most, if not all, of the departments of federal government and regulation and infrastructure. And so I really want to focus in on some of the recommendations around sexual orientation and gender identity. I want to focus in on some of the recommendations around gender-affirming care and really show how this links back to this larger conversation of bodily autonomy and our ability, again, to be self-deterministic over our own well-being. Mm-hmm. So some of the pieces that I think are important for us to be aware of is that in this document, there are recommendations to strip away non-discrimination policies, to revise and stop following Bostock versus Clayton County, which expanded non-discrimination in Title VII to include sexual orientation and gender identity. Caveat to note with that is that courts have already stopped the enforcement of that. Portions of this are also becoming moot points. But I think it's important for us to acknowledge anyways that as exists now, workplace discrimination can occur for folks who are LGBT on the basis of their sexual orientation and gender identity. And unless the state has a specific restriction around it, or the city has a restriction, or the organization has policy in place, then there is not necessarily a way for us to prevent that from occurring. So This is recommending continuing to erode our ability to be employed and to show up fully in our work. There's also recommendations from this document to remove language from federal policy, from grants, from regulations, removing words specifically like sexual orientation, gender identity, gender expression, diversity, equity, and inclusion, abortion. And so actively trying to erase some of the nuances that have been put into regulation and into grants in order to support and get funding into the communities that are often disproportionately impacted negatively by social determinants of health, or have barriers to accessing care or accessing employment, etc. So
Mhm.
we're seeing an active push to remove language from federal spaces that advocates like myself have worked really hard to include, because we know that when left in a more vague sense, oftentimes those who are most marginalized are the ones that are left out from access to resources, from equitable services that are coming into our communities in ways that we need them.
Mhm.
So those are some of the big pieces that I'm particularly concerned about. I'm also concerned about the fact that they are a characterization of gender affirming care as inherently dangerous, and to remove and restrict gender affirming care support from a governmental standpoint, including no longer allowing gender affirming care coverage via Medicaid, which, as we know, in terms of social determinants of health and the health and well-being of trans and non-binary folks and the treatment of gender dysphoria, gender affirming care is one of the ways that we treat gender dysphoria, and it's going to look different for each person. It might include medical transition, but for those who are undergoing medical transition, it is to treat gender dysphoria, and gender dysphoria, when untreated, is linked to suicidal ideation, depression, anxiety, mental health concerns, and also physical challenges in our bodies as well, and physical health concerns as well. So
Mhm.
there's this characterization that's occurring that all gender affirming care is inherently dangerous. And as we have seen with anti-trans legislation pushes over time, we're seeing this ramp up, going from just restricting gender affirming care for minors, for those under the age of 18, to now attempts to restrict gender affirming care for adults as well. So we're also
Mhm.
seeing, again, this stripping away of bodily autonomy, our ability to make informed decisions about our medical needs and our health and well-being, with the specialists who and the clinicians and medical providers who are aware of how to treat and serve our community. So we're seeing some real concerns around that. And so that's all just like the health piece.
Mhm.
One of the other big pieces that I think is important for us to not only highlight, but to be really aware of the implications of, is the way that trans people are talked about in the document. Trans people are referred to as this transgender ideology. And something I really want to make clear is that there's no such thing as a transgender ideology. Trans people exist. And what they're talking about is affirming trans people and trying to equate affirming trans people and being supportive of trans people as somehow infecting other people with transness. But we know that that's not reality. Social contagion isn't a real thing when it comes to trans identity. And so the way that it's being characterized in this document is that trans people, because I'm not going to say trans ideology because it's trans people they're talking about, is that trans people are equated to pornography, and that
Mhm.
pornography should be criminalized. And so there's this push to criminalize pornography, and as a result, and in effect, also criminalize trans people and criminalize those who support trans people. And so they make a point to point to librarians and educators who support or propagate pornography, in this case connected to trans affirmation, as having to register as sex offenders. So there's this
Mhm.
real clear connection with how they're trying to actively criminalize trans people out of existence and push trans people out of services so that we are not able to get our health needs met.
Mhm. It's an unfortunately it's a flashback of history in America where othering is it's coming back, but it's coming back at a dangerous rate where it's going to affect on a public health scale where you are going to see mass harm to not
Hmm.
just the LGBTQ plus community, but associated communities, women who
Yeah.
support, other people, men who support the LGBTQ plus community.
Hmm.
Another thing that I wanted to point out too is that whenever they're putting these, and for people seeing visually, I have this mandate on my screen, on the other screen next to me. That's why I'm gesturing this way. They talk about the gender affirming care in a negative way, but the thing is that the way they map this out, it affects cisgender women, cisgender men. If you are seeking gender affirming care, this affects you too.
The first thing I'll say is that I think fear is used oftentimes to manipulate us into being, we are often taught to fear the other, and fear is often used as a tool or as a tactic to manipulate us and groups of people to do specific things. And I think because we're in an election year, we're hearing a ramp up of fear tactics really on both sides of the political spectrum. And one thing that comes up for me around this specifically, and what I've seen from my work, is that there is this fear of gender affirming care is not well understood, is not well researched, is not clear, and that gender affirming surgeries are happening on folks who are under the age of 18. And so that's been used as a way to push this anti-trans legislation, especially for minors, but now is being used to extend that up to folks ages up to the age of 24. So again, we're talking about adults now, or folks who are able to legally give consent. So there's this push now to say like, oh, well, surgeries are taking place, surgeries are taking place. And the reality is that most surgeries, and I think we talked about this on the last episode that I was on, is that most surgeries that are taking place on folks under the age of 18 for the purposes of reforming genitalia are happening non-consensually, and they're happening to intersex infants. And actually all of the legislation that's been pushed forward that is banning gender affirming care for minors has carve-outs to still continue to perform surgeries on intersex infants to form their genitalia into what would be expected of a male or female infant. And so I think it's important for us to really point out that there's a lot of inconsistency, and it really is rooted, when we want to talk about ideology, it's really rooted in this idea that gender can only be one immutable thing that is directly linked to a person's sex at birth and is directly related to their biology. And when their biology doesn't match, then we will make their biology match what we want their gender to be. So it really becomes clear to us that there's just this cognitive dissonance around understanding the diversity of gender and even like biological sex for human beings. And I think that one of the reasons this becomes so challenging as a playbook, like it's really being tied to Trump and the Trump presidency and the next conservative president. But I think it's also important for us to keep in mind that this is clearly outlining a conservative ideology that can be used down ballot, that can be used across spaces. And so I wouldn't be surprised if bits and pieces of this start to get implemented in places across the country, even if it's not happening on a federal scale. And I don't say that to stoke fear, but I say that because I think that means that for those of us who feel sometimes hopeless in these spaces, that there are things that we can do to prepare for ourselves and that we can do to take care of ourselves and our communities in order to help ourselves become a little bit more resilient when changes do occur, or if they do occur. And really this is getting back to, and I really want to focus this back on, this is related to bodily autonomy. And so we've talked a lot about gender identity, but parts of this document also talk about the expectation of family structure in a home, that a family structure has to return to a nuclear family, that a man and a woman need to be present as parental figures within a household. And so we start to see this erosion of lesbian, gay, bisexual families. We start to see this erosion of fostering as same-sex parents. So like we know that there's like shifts that are occurring that are impacting cisgender people as well within the LGBT community as a way to push away from supporting LGBT people in general. And you mentioned at the beginning a little bit about the discussion that you had shared on abortion and the ability to choose and all of these pieces. And I think it's important for us to, again, link this all back to bodily autonomy and our ability to be self-deterministic in the ways that we build our lives and the ways that we support our own health and well-being and cultivate families for ourselves. And one of the things that happens with bodily autonomy, especially around abortion, is that we're seeing that there are recommendations to reinforce the Comstock Act, which is an old anti-obscenity law to prosecute providers and distributors of abortion medications via mail, that we see a banning of mifepristone. I think I'm mispronouncing that. Medications have wild names, mifepristone, which may lead to additional medication bans for other medication used for abortion, which we might also see as there's other like gender affirming care medications. We might see that there are more restrictions that take place as well to prevent folks from being able to have access to their medications. And we're also seeing that there's a push for states to report how many abortions are provided within their state lines, the gestational age of the fetus, reason for abortion, the mother's state of residence, and the method, and any complications from abortion. And now I want to say that it makes sense to me that we would want to collect surveillance information to better understand the health and well-being of the communities that we are serving. And if we are seeing trends that, for example, we're seeing more mortality or more severe side effects or symptoms from what is occurring in our state, right? We want to see those things so that we can address them. It is a public health model, but this is being connected specifically to abortion tourism because medical restrictions are taking place in different states, and we see this same trend happening for gender affirming care. And so what ends up happening is there's this big fear that ultimately we will be trying to get our medical needs met. In this case, someone might be seeking an abortion, and that they will end up on a list where their information is being disclosed to an entity that will put them at further risk of destabilization, of employment challenges, of legal repercussions, etc. And I don't think that that is far-fetched from reality, even though we have HIPAA laws and our medical records are supposed to remain confidential. And I say that I don't think it's far from reality because at the end of 2022, 4 states, Tennessee, Missouri, Texas, and Indiana, their attorneys general all requested health records, medical records from health centers and hospitals on folks who were receiving gender affirming care. And though a lot of those health centers and hospitals pushed back or refused to provide that information or actively said like this is in violation of HIPAA or sued the attorney general around it, we know that Vanderbilt University Medical Center disclosed and sent over 65,000 medical records and disclosed the identities of 82 trans and non-binary people who were receiving gender affirming care. So we know that this is something that is not outside of the concept of reality, that there could be very much like real world implications to our health and well-being, our stability, our ability to continue to get our needs met, and our safety as well.
Mm-hmm. And talking about this, so moving on to the next thing up, how continuing the broadly impact of marginalized communities. So when we were preparing for this discussion, we were talking about how when new legislation is introduced, even if it doesn't pass, it can create confusion among healthcare providers and leading them to believe that they can't offer certain types of care and, gender affirming care, hormone therapy, so on and so forth. And despite their ability to continue to do so. So can you talk about how this affects providers and their confidence in being able to provide that care for those folks?
Yeah, absolutely. Well, the first thing I think of is that if we are constantly seeing new legislation being introduced that's saying we can or can't do something, then it becomes even more confusing to us about what we are legally required to do or restricted from doing in terms of providing care. And one of the things I think about with gender affirming care is that sometimes gender affirming care is discussed as specifically medical transition related care. So gender affirming hormone therapy, gender affirming surgeries. But we also know that there is a lack of foundational knowledge about trans and non-binary people within health environments, with our providers, with our support staff, with our clinical care teams. And so it is also not outside of the realm of possibility that trans people will attempt to receive medical care for some other reason, such as an emergency room visit or diabetes management or what have you, and be denied care if there is a perspective, an understanding, or a misunderstanding that serving a trans person is providing gender affirming care. We see this sometimes. It's called also trans broken arm syndrome, when trans people will come in for some sort of health condition and everything will be related back to their gender affirming hormone therapy or gender affirming surgeries. And so if we're already making this misconnection to, well, it must be because of your hormones that this medical condition has occurred, then again, I don't think it's outside of the realm of possibility that a provider might be like, and I can't do anything about your gender affirming care because it's illegal within the state for me to do X, Y, or Z. So I think
Mm-hmm.
that there undermines the therapeutic relationship with our patients and our patient provider relationship with patients. I think that it will make it harder for providers to engage trans and non-binary patients and retain trans and non-binary patients in care. I think it will increase barriers for trans and non-binary people to get their care, because we know for
Mm-hmm.
a lot of trans and non-binary people, part of the incentive for care is getting access to gender affirming hormone therapy. And so that's one of the reasons why a lot of linkage to care programs focus on holistic care. Are we getting you your medication for example, for someone who might be HIV positive? Are we getting you your antiretrovirals? And also, are we able to connect you with and help you monitor your hormone levels and get gender affirming hormone therapy? So there's a lot of interconnection that happens because it helps to retain folks in care.
Yeah.
But the reality is, if this continues to move in the direction that it's moving, that it's going to become harder for providers to retain folks in care, to engage their trans and non-binary patients. And I think you're going to see even more fear from your trans and non-binary patients around disclosing or talking about what's going on with their health. I think you're also going to see more trans and non-binary patients who are seeking gender affirming therapies, so surgery and hormones for medical transition specifically, from places that are less reputable or that don't have as much like regulation and oversight for
Mm-hmm.
those services. So I wouldn't be surprised if you serve trans and non-binary folks, if you started seeing folks who are getting hormone replacement therapy from third party sources and were taking those hormone therapies without like lab work or management of their hormone levels.
Gosh, it's kind of like going back into the dark ages.
Yeah, well, and I think about it too. So it's also the way that I'm going to phrase this is in the way that I'm going to phrase this might come off a little trite, so stick with me. But it is also a privilege for us to be talking about what it means to lose access to these services, because there are lots of folks within the trans and non-binary community who don't have access even when it is legal to receive
Mm,
gender affirming hormone therapy and gender affirming
yeah.
surgeries. One, not all trans and non-binary people are interested in medical transition. But for those who are interested in medical transition, there are lots of additional barriers to receiving that care in the United States, including the fact that there are financial barriers to receiving health services. Lots of providers don't know how to treat us as trans and non-binary people. And I mean treat in the medical sense, but also just treat us as human beings. And so there's lots of ways that we are pushed out of care. And I know we focused on that during Pride Month, but there's lots of ways that we are pushed out of care in general. And the folks who experience that disproportionately within the trans and non-binary community are Black, Latine, and Indigenous trans and non-binary people. And folks who are also lower on the socioeconomic scale, folks who are in more rural areas. So we know that this is something that isn't even available to all trans and non-binary people who are looking for this kind of medical support. And so talking about it restricting or as you mentioned, like going back to the dark ages, for some of our community, that's where they already are. And so
Mm-hmm.
I think what we're seeing right now is a pushback from us trying to create more avenues to equitable care within our community and trying to create more avenues to getting folks to a space where they are able to maximize their health potential and not just survive a system.
Mm-hmm. And this kind of goes back to when you said privilege, it just occurred to me like my sibling had the privilege to be able to have access to all of these resources to support him through his journey. And I forgot for a brief moment, I really did. I forgot that how much of a struggle it is for others, and that's terrible to do. I
Hmm.
don't mean to do it because I'm seeing it from my experience is based off of somebody else's experience who had it easy.
Hmm.
So I'm not exposed to those stories, and I think we have a tendency to forget that.
Hmm.
Maybe people like myself, you are like in the field on the ground, you're doing the good stuff, so you're the superhero in the cape in this instance.
Thank you. I think sometimes this can become really heady and theoretical. And so I want to give an example to illustrate kind of what I'm talking about when I mean that overall we're going to start seeing like we're going to see the health of our community start to deteriorate, because when we have lack of access to services, when we have services that don't treat us in an equitable way. And what I mean by equitable is giving us what we need in order for us to maximize our health potential. So
Yeah.
you and I, for example, we might be given the exact same medication for a let's say we both have cholesterol issues. We might be given the exact same medication, and that might be equality, right? We're given the exact same thing, but you might experience challenges with picking up the medication from the pharmacy. You might have barriers to transportation. Maybe you don't have a car. Maybe the cost for your copayment is too high, whereas
Mm.
I have a vehicle. I'm able to get a pharmacy. I have health insurance that allows it to be mail order, right? So even though we're given the exact same thing, the way that it actually is used and consumed by us, or the way that it actually is going to be of service to us, is different. And so I might see my cholesterol levels go down and you might not. But if we were both given equitable care, then it would be, I'm given the medication in a way that I'm able to receive it, and you are given the medication in a way that you are able to receive it. So it might mean helping you get onto a program that covers the cost of the medication, connecting with a pharmacy that's able to mail the medication to you, even though you don't have a mail order pharmacy with your health insurance, if you're
Mhm.
insured at all, helping get that medication prescription sent to a pharmacy that's within walking distance to you, as opposed to the hospital pharmacy, right? So we're talking about giving folks what they need to maximize their health potential. And in the previous comment on how this is going to impact trans and non-binary people's care overall, I was just talking to one of my best friends 2 nights ago about their experience with being diagnosed with epilepsy. And we were at a camp together and had been there for a few days, and they had a seizure, and it was the first time they'd ever experienced a seizure. And they had to go to a primary care physician in order to be sent to a specialist to be evaluated. And when they saw the primary care physician, without asking a question, without providing assessment, the physician said, well, you're confused about your gender. You think that you're a man and you're drinking like a man would drink, and you can't drink like that. And that's why you had a seizure. And so then they had to go and find another physician in order to get sent to the specialist. And by that point, they had had a second seizure. So it was clear that there was actually something underlying going on neurologically. And they ultimately were diagnosed with epilepsy. But if we
Mhm.
have these connections that gender identity it is the pathology. Gender identity is the issue, and all of these other things are happening because of gender identity, then we are doing a disservice to the overall health and well-being of the person. And so
Yeah.
if we're being told we can't treat trans and non-binary people for their gender identity, then if we're relating seizures to gender identity, then we are not going to be able to treat that seizure in our mind, potentially, because we might think to ourselves, well, I can't treat gender identity. I can't treat gender dysphoria. Right.
Mhm.
So I think that this illustrates how quickly this becomes a challenge for providers, and how convoluted it becomes when it doesn't need to be this complicated. Like, yes, gender is complicated and the theories around these things are complicated, but serving our patients isn't actually very complicated. We just have to take a trauma-informed approach to providing care, and an equitable approach to care.
Mhm. Amen to that. We can't close on that, but could I love that response. Perfectly said. They're human at the end of the day. We don't need to have any questions about it. Like, yes,
Mhm.
treat humans the way you would want to be treated with
And
care.
treat humans the way that they want to be treated. Because
Yeah.
for example, I don't lots of people mispronounce my name all the time. People mispronounce my name all the time. And it's not necessarily a big deal for me because it happens a lot. And I'm in a place now in my life where I can just correct it. But I might be seeing someone who, for the first time, is going by an affirming name for them. And if I default to a legal name, for example, then that might be much more intense for them than it is for me. So I don't want to just brush it off as like, oh, well, it's not a big deal for me, so it's not a big deal for them. I want to meet
Yeah.
that person where they're at. I want to treat people the way that they would like to be treated.
Yeah, that patient-centered approach, just
Hmm.
patient first. It's
Yeah.
absolutely. So to close this out, let's talk about the fun things. We can make them fun. You can throw it around your hands and stuff. The actionable steps for protecting bodily autonomy. So
Yeah.
you had a beautiful way of how you put it out. The four, I'm calling these the four pillars. Um, the individual level, the organizational level, community advocacy, and then empowerment. Would you like to lay down each one for us?
Yes. So some of the things that I would like to, well, what I would like to mention first is that when we are talking about, and I'm just pulling up my note over here because I want to make sure that I'm really clear in what we're talking about. But one of the things that often comes up when we talk about our community's harms, right? Or the way that our community is treated, or what's happening when it's larger than us, what's happening when it's federal, right? Is there's this
Right.
feeling of hopelessness. There's this feeling of like everything is becoming awful, everything is becoming terrible, everything is shifting in these ways that are going to harm me. And I think that we can hold that, right? We can hold the reality of that fear and also acknowledge that we have control over the ways that we are going to move and we have control over the ways that we are going to prepare. So what I mean by this is really taking an approach of resilience building when it comes to big news like this, because the reality is I don't have control over what the federal government decides. As an individual, I don't have control over that. I don't have control over what the elected city officials decide. I don't have control over what is happening in my state necessarily, right? So I have to lean into what do I have control over and what can I support, or how can I support myself, my siblings, my family, my community. And so I hope that this section is helpful in terms of showing you that even if it is starting to feel hopeless, that there are still ways that you can support yourself and the people that you care about and the communities that you care about, and that we are actually a lot more resilient than we realize. I was actually talking to a friend this morning about how one of the things that helped me to feel more resilient when I started doing this work in public health over a decade ago was learning about the history of what folks had to navigate during the late 80s, early 90s during the HIV crisis. And so I could get a better conceptualization of like we have worked through the things and we have made progress, so it doesn't feel all doom and gloom.
Mm-hmm.
So at the individual level, there are things that we can do to protect ourselves. There are things that we can do to prepare as well. And so it might include identifying healthcare, ways that we can continue to have our healthcare managed and have received the healthcare that we deserve and that is dignified and is affirming. So for gender expansive folks, then this can look like, for example, if you're living in a state that is starting to move towards anti-trans legislation or restriction of gender affirming care services, look at where's the closest county where you'd be able to potentially go and receive gender affirming care. Are there any mail order pharmacies or telehealth providers that are still working within your state that are able to still provide those services? Are there any organizations locally that are advocating for gender affirming care or developing peer support spaces? So these are all individual things that we can do to start to prepare for how we will support ourselves. If you
Mm-hmm.
are if you're receiving medication, so if you're on testosterone or if you're on estrogen and testosterone blockers, are you able to refill your medications as early as possible so that you can have sort of a little stockpile for yourself? And I actually recommend this for all medications for folks, really. I receive like a daily medication that's a 30-day, and at day 25 I can refill it. So every month at day 25 I refill it until I have about a 60 to 90-day supply. So that way, if something happens, if my insurance ends, if I can't afford to fill my medication, if policy changes and there's an issue with getting my prescription from the pharmacy because it needs like a new authorization from my doctor or something, or if there even just like as a medication like a lack of medication manufactured, and so their pharmacies all over the country are having challenges getting the medication, then I'm not potentially breaking my cycle. I'm not missing out on my medication. And so I recommend
Mhm.
that with really any medication, because our system is set up in such a way that it can be very difficult when we do have those breaks in medication to restart or to get back on it quickly. And that's a lot of additional stress and worry and fear and anxiety on ourselves. So a way we can prepare ourselves is to start now with that process, so that you have a little bit of a stockpile in case something does happen. Like I have 90 days of my medication right now, and I'm about to get a refill, because I know that if something were to happen, about 3 months would be enough time for me to find a new pharmacy, a new physician, to find a mail order pharmacy, etc. So those are
Mm.
some of the ways that we can prepare for ourselves and take care of ourselves at the individual level. At the
Yeah.
organizational level, it gets tricky. Lots of organizations are, well, some healthcare organizations do lobby. Some for-profit healthcare organizations do lobby. Lots of nonprofit agencies, part of receiving the funding means that they are not eligible for lobbying, and that if they are lobbying, they can lose federal and state funding. And so
Mhm.
it's identifying like what is our scope and how are you the experts, and providing resources and information around that expertise. So for example, you might advocate for policies within the workplace that maintain protections regardless of federal rollbacks. So we mentioned before that there's this push to remove SOGI from sexual orientation, gender identity from federal regulations, from non-discrimination policies, to no longer connected to Title VII with Bostock versus Clayton County. So as an organization, you can advocate to include those sexual orientation and gender identity as part of your non-discrimination policy. You can work
Mhm.
internally to develop policies that support trans and non-binary people in being hired, maintained, and retained as talent, in transitioning in the workplace, and being supported in the workplace, and being referred to by the name and pronouns that they go by. These are all things you can do within your organization. If you're an organization that works in public health or healthcare, you can also do things like write research briefs and provide white papers on things like abortion and gender affirming care and the health and well-being of the sexual orientation and gender minorities, right? So there's ways that you can still use your expertise to then support the folks who are eligible to do lobbying. And really that is your expertise, right? So if I'm working at an HIV organization, which I have in the past, I'm working at an HIV community based organization, and our goals are to prevent HIV, prevent hepatitis C, and prevent substance use and all these other things as a public health agency. Then we might release a white paper talking about what the research shows around these experiences for gender expansive communities, and some of the facilitators to care, having affirming providers, having an organization, a medical provider that provides both substance use treatment services as well as gender affirming care. So these are ways that we can use our expertise at, not in a lobbying sense, but to provide information out to our communities that is reputable and credible, and that they are able to then institute in their own organizations, which really gets us into the next level, which is the community advocacy. So doing things like supporting state level legislation that can buffer against those federal changes. So doing things like codifying protections into state law. There's also discussion about rolling back same-sex marriage. And so like that has raised a lot of red flags for LGBT couples and queer folks in general, as well it should. But if that is being talked about rolled back in a federal way, then the default would be to state levels again. And we saw this with Roe v. Wade, right? So we know that it's not outside of the realm of possibility, especially because we know that Oberfeld it has not been around as long as Roe v. Wade was, for example. So we know
Yeah.
that this is not outside of the realm of possibility. So what can we do as a community advocacy agency, or as an individual, to advocate at the community level for codification into law? So for example, I currently live in Colorado, and there's now a push and an initiative to codify same-sex marriage into law, because when it was in the process of being voted on, the federal ruling came out. And so suddenly every state had same-sex marriage. And so as a result, that never got passed. So if that were to get overturned at the federal level, there wouldn't be same-sex marriage protections or options in Colorado. So
Mhm.
it's identifying where we can kind of get ahead or prepare again for if this changes, we are still protected. And then in terms of this like fourth thing, which is the more nebulous empowerment, right? We still have control over our own bodies, even when we are being told we don't have control over our own bodies. So we still, individuals and organizations have control over certain aspects of of advocacy, and we have control over ourselves. And I mentioned earlier, like what privilege looks like in this as well. Part of what we are taught, and part of the reason why some of this feels hopeless, is because we're taught to work separate from one another, that our needs are not the same. The needs of abortion rights activists are not the same as the needs of gender affirming care activists, for example. And not even activists, but like folks who support are pro-choice. Those needs are not the same as those who support gender affirming care. But the reality is, because these are all about bodily autonomy and our ability to receive the medical care that we deserve and health and wellness that is in connection with the professionals that we hire to support us with that, right? Medical professionals, that actually we have a lot more in common than we have dissimilar. And the other reality is that our communities also overlap. There are trans and non-binary people who are in need of reproductive health services, and that might be abortion services. It also might be family planning services and contraception and fertility services, et cetera, right? So there's overlap. There are cisgender women who are able to conceive, who are also doing pro-choice work, who may also need access to gender affirming care, like gender affirming surgeries or hormone replacement therapies. So there's more similar than there is dissimilar from one another. And I think what we can do in terms of this empowerment piece is figure out where our similarities lie, so we can focus on a community mobilization and how we can stand together to support across our community. Because the resources that I have in the work that I do are going to help fill the gaps in resources that other communities have, and vice versa. And the ways that we do that is by coming together and again, recognizing those similarities and those commonalities. And one thing I really like to lean on is the parable of the choir when I'm doing any of this work, because we can feel so isolated and so siloed so frequently. But the parable of the choir is that a choir can sustain a note for however long you need it to be sustained. Because individual voices might drop out to take breaths and then come back in, or they might become fatigued and they might need a short rest and then come back in. But the choir as a whole can maintain that note for as long as possible. And so I like to remind myself and remind other members of my community that when we lean on one another, that's us taking those breaths. It's us helping to support one another, so that when we need to drop out and catch our breath and reset and refocus and center and take care of our mental health or our physical well-being, then we're able to re-enter when we are prepared and we are in a more grounded and stable state. And so I think what I hope to leave folks with is that even when these things are occurring, even when we are experiencing like these really intense pushes, and even when we're being taught the fear aspect of it, to remember that like we still have a lot of control over what we can do, and that we are not doing this work alone, and we are not caring for our communities or our patients alone.
That's a beautiful way to end it. I love that. I say that a lot with a lot of these things, but that was beautifully put. Thank you so much, Miss Jai, for coming and speaking with me about this. It's hard to talk about these things, but that last note, I do hope as well that like this gives everybody that empowered push. Like, we can do this. We can get through this. So
Yeah, I believe in us. Thank you for having me, Liz, and for highlighting these pieces. It's been in the news a lot, and there's a lot of concern around it, but I really appreciate tying in the broader picture of how this is related to our bodily autonomy and what we deserve.